Hello and welcome to Askimo TV. I'm talking today to Saghar Kasiri. Saghar is a senior clinical embryologist and PGD coordinator at London Fertility Centre in Harley Street. She's been a specialist in the field of embryology for 18 years and worked in top IVF clinics in the UK. Saghar has made 4 TV programs on infertility, been interviewed by BBC, and written a number of articles on infertility and assisted conception techniques. Hi Saghar, how are you?
Hi Joanne, how are you? You okay?
Very well, thank you. Saghar, today's topic is going to be assisted conception techniques. So can you list the various assisted conception techniques?
Sure. Well, first of all, with assisted conception techniques, we have we can look at it in a way of whether we're talking about stimulated cycles or unstimulated cycles. Stimulated meaning that we produce, we give drugs to the patients to produce more eggs than they normally and naturally do. And unstimulated cycles is when they actually we take them through their own cycle and try and retrieve the egg that they produce per month, or even give them basic helping hand with the eggs that they have just produced, and just inject them with a sperm that we take from their male partner, and we purify that sperm and put it inside their body. So if I wanted to start, I mean, perhaps the one of the simplest techniques that would help patients that may have very mild form of infertility, and that's if the patient's partner is producing good quality sperm that can be used, is unstimulated or natural cycle IUI, which is intrauterine insemination, where we just basically just get the male partner's sperm purified in the lab and just inject that sperm inside the uterus at the right time of the month. Okay. So then we obviously have the same IUI technique, but with a stimulated cycle, where we give some drugs to make the female partner produce perhaps maybe 2 or 3 follicles that month. Then, of course, the stage after that is IVF. Again, with IVF, recently in the last few years, a technique has come out called in vitro maturation, which is called IVM, and that's a sort of more natural IVF cycle, if you can call IVF natural by any means. But it basically means that the patient produces a number of eggs, and very few number of eggs, so there's no risk of hyperstimulation with that. And then we retrieve those eggs quite early on and let those eggs mature in the lab. Okay, and then of course you've got the IVF, which revolutionized the assisted conception technology in 1978, when the first IVF baby was born, Louise Brown. And IVF is very much for ladies that have got problems with the tubal defect or female-related problems, and then we had another revolution in assisted conception techniques in 1992, when a technique called ICSI was introduced. Now ICSI for men does what IVF does for women, basically. A lot of male infertility issues that couldn't be helped with just using IVF was overcome by using ICSI technique, which is intracytoplasmic sperm injection, which we actually take just one sperm, that we need one good quality sperm that we can actually inject inside one egg. So instead of needing 100,000 or 150,000 or 200,000 sperm per one egg for IVF, we only need one sperm per egg for ICSI. And then there are other techniques. I won't go through it too much, but there is PGD, which is pre-implantation genetic diagnosis, that helps couples who've got hereditary genetic defect, and also PGS, pre-implantation genetic screening, which would help couples that, for example, of older age, or perhaps those that have had quite a few miscarriages in the past, and those that may have had abnormal pregnancies with chromosome abnormal babies. And we also can do donor insemination. So if a man doesn't have any of his sperm that we can use for IVF or ICSI, we can use from sperm donors. If the female has got problems and would not be able to produce eggs for IVF, we can use donor eggs for that as well. And of course, any of these techniques, if we've got surplus embryos, we can always freeze those. We call it, now we have a very good technique called vitrification. We can freeze and then later on thaw, or as they say, defrost the embryos to use for the patient. And if the patient has got their own gametes or their own eggs and sperm they can use, but there is a problem with their uterus and they wouldn't be able to actually carry a baby, then of course we can try the surrogacy route, where we have another lady that would agree to carry the baby until 10. These are the main
Saghar,
ART techniques.
Just to end off, how many times would you try each of these techniques for?
I think what's important to remember is not to repeat something that's not working for too long. For example, RUI can be done every month, so the ladies don't have to wait for too long. But what they need to realize is after the third, fourth, fifth, and definitely after the sixth attempt of doing RUI, if they haven't got pregnant, then they really should stop doing it, and they should look into perhaps looking at doing IVF. And the same thing, if for example you do IVF and you have failed fertilization and you haven't managed to get eggs or embryos, then perhaps you need to look at ICSI. But the clinicians and the embryologists can explain to patients what would be the next step forward and what would work better for them, perhaps.
Thank you. Thank you so much for talking to me today.
Thank you, Joanna. Thank you, Askimo TV as well.
Pleasure.